Good morning, lovely people. This is awesome. So if I count correct, 8 potential hospitals in the room to become ChildKind certified. That's very groovy. So I'm Stefan Friedrichsdorf. I'm a pediatrician from Minneapolis, Minnesota. And who's from St. Paul? From Gillette or where are you from? Okay, we have to talk. I didn't know you were here. Cool. Neil and the gang asked me to talk about one major project which we've done in our children's hospital for the last 3 years, the Comfort Promise. I'd be very happy to do that and to talk about how can we do everything possible to prevent and treat pain every time for every single child. So Minneapolis, St. Paul is right there. So it is very much in the middle. We just had some discussion of the country. Well, maybe not, but. I put the slides up, so if you want them, and I think Carrie is going to pass this out as well. So I just put them on noneedlesspain.org without the www, noneedlesspain.org, so you can download the handouts of the slides. If you like, if you're not on Twitter, hopefully by the end of the day you are. There's lots of information at ChildKind Intel is the Twitter handle for ChildKind International, and I'm No Needless Pain. There's lots of interesting stuff coming up. At least half the articles I read I get through Twitter, so it's really, really worth signing up. So this is my second cup of coffee and counting, and I will have my third. And I'd like to quickly introduce you to my top 3 reasons for drinking quite a bit of coffee, and here they are. So we're basically fairly active kiddos who are mostly pain-free, but they are very much doing dangerous things in the park, very close. Usually what it looked like actually in my household for the last 10 years is more like this. So, child-kind, baby-friendly. Anyhow, let's talk about, we have 58 minutes left, about really needle pain. Yeah, because it seems to be that this is an important topic on the head of many, inside the head of many of our kids. And what are sort of the non-negotiable components in 2017 if we want to prevent or minimize needle pain for children? And then I thought I'd tell you a little bit about our journey, what we've done over the last 3 years, and it took about 10 times as much work as we thought it would to push something like this through. So about 2 years ago, I was asked to speak in Copenhagen for a Nordic anesthesia group, for a pain group, and they showed that movie, and it was like a documentary about this nurse actually. And so if you do not understand Danish, it doesn't really matter, but this is a 5-year-old boy by the name of Marius, and Marius just had an accident and he needs stitches. So he comes into this emergency room, or the equivalent of that in Denmark, and things are going well. It's a really nice nurse, they have stickers, everything is fantastic. And then something is going wrong. And I wonder whether those of you in the front who have not seen this, the back has, can tell me what went wrong here. So it's appropriately sad. Stickers, awesome. And bubbles, love it. It's very compliant. Showing this, and they make the decision, yes, you need stitches.
En 5-årig dreng kan godt være rigtig stærk, så vi er nødt til at hente noget forstærkning, så han kan holde ham fast. Og bedøve fingeren, og vi ikke nogle flere kollegaer, og så er vi 5 voksne mennesker, der er nødt til at holde hans lille arm, for at vi kan få det.
So those of you who do not understand Danish, what is he saying? Shall we quickly count how many adults are holding down this 5-year-old boy? last year I was asked to give the plenary for the American Burn Society. There were more than 2,000 people in the room. It was my biggest gig I ever had. So I was sort of talking there. I showed that movie. This was every single burn center in North America, most burn centers from the Western world. I showed this movie, said, how many of you are certain that this cannot happen tonight in your hospital? How many hands went up? Not a single one. This has to stop. Yeah, you're so sweet, Dr. Friedrichsdorf. I mean, it's like, Stefan, really? We just don't have the staff for pediatric pain control. It's amazing that we always seem to have enough staff to restrain a child. So I love Neil, Alan, all of you who are on this ChildKind initiative. This is absolutely awesome. Yeah, the Declaration of Montreal in 2010 said that access to pain management is a fundamental human right. It's a human right violation not to treat pain. So how are we doing right now? As Neil just said, we are under-treating pain. But when parents come to us, when kids come to us, to our care, they assume that we do the bloody best we can possibly do to take pain away. They assume everything possible is done. They say, it doesn't matter if I go to Worcester or UCSF or to Seattle or to Minneapolis. It doesn't matter where I'm going. If I go to Gillette Children in St. Paul, it doesn't matter because any children's hospital obviously is going to provide state-of-the-art best pain management and prevention and treatment. And those of you who work for more than 10 seconds in the system know nothing is further from the truth. Yeah? Even if you just check, okay, what are you guys actually doing? Like, it's all over the place. Great study just came out showing that, yeah, whether or not pain medication is given in EDs, how much, for what reason, changes like from one ED to the next one. And there's no rhyme or reason for that whatsoever. And Neil already mentioned, if you actually ask parents, okay, what is your number one priority? Why do you come here and not there? They say, well, first, treat the underlying condition. Then second highest priority on the mind of the parents is pain management. What's the number one priority of the child's mind? It's pain prevention. So what we're talking right now, when I talk to my CMO, CFO, I tell them that's like, we're not talking about this little hobby of mine. Yeah? We're talking about the number one priority of every single of our patients, and number two of the parents. There's nothing worse for a parent to see their own child being in pain. We also know that the younger kids are, the less likely it is that they get appropriate analgesia. In other words, a 17-year-old teenager is going to get much better pain control than a 17-month-old toddler who is going to get better pain control than a 17-day-old infant for exactly the same underlying condition: chest tube, surgery, interventions. So why bother? I mean, why are we sitting here? This little bit of pain thing, I mean, it's like, you know, I mean, it doesn't build character like pinning Marius down and put the needle in. No, it doesn't. Turns out that kids who are suffering from unreleased pain turn out to be adults with a much higher degree of anxiety, depression, and much higher risk of developing chronic pain. If we do something stupid, if we do something unethical, as we just have done, like holding down a child for a painful procedure, this child will require more analgesia, more anesthesia, and more men and women power the second time he or she is coming. We are creating those monsters which bring the whole system to a stop. We are creating those kids from the first place because we haven't thought about this the first time. We do know that kids, in fact, develop post-traumatic stress disorder after trauma, after accidents, if we have poor analgesia. In fact, the more morphine we give, the less likely it is that they do develop PTSD after a burn or after trauma. So what we really need is multimodal analgesia. There's nothing worse for a parent than to watch your own child being in pain. So our philosophy here at Children's is no needless pain, which means often drugs. It means right form of distraction like blowing bubbles, using self-hypnosis, music therapy, the human touch, making sure that their parents can hold their child, that whatever's helpful for this particular child. And if you have access on pain control, if you're really comfortable, children are actually able to heal much faster. So these kind of pieces of propaganda are really helpful. This is just an ad was running in the Twin Cities area. Like, there's competition. They can go to Gillette, they can university. We want them to come to us. Yeah. So our marketing office uses this kind of stuff. So now, if I come, there are 8 7, 8, 6 hospitals in the room right now. If I come to your hospital, if I come to Worcester, if I come to UCSF and I ask every single child, what is your number one thing, what you're most worried about today, seeing a doctor? What is the answer? Hands down, of course, it's the needles. We published that in the Journal of Things We Already Knew. Yeah, kids are really, really, really afraid of needles, because when they come to us, this is what they get. This is what they see. If we do something stupid, it actually, as we know, significantly influences the experience during subsequent procedures. And preemies and neonates have unrelieved needle pain actually rate their needle pokes much higher than kids who haven't years later. There's poorer cognition and motor function associated with higher numbers of skin-breaking procedures, for all that matter. And then every day, there are about 350 children dying of measles in the world. 350 kids are dying today of measles. And of course, most of them are in low-income countries where there's just not vaccination. But we have in Minnesota and California and other areas, we have high pockets of parents who choose not to vaccinate. And half of them are insane for insane reasons. But but for half of them, it's actually, if you literally look, why are you not vaccinating the kids? It's actually the pain. Including my own mother. Apparently I was such a wimp that she stopped vaccinating me, and I did get measles at my 10th birthday and gave it to another 4 children. And I've actually seen 5 children dying in my care so far in Western countries of measles. So this is not just a little cute topic we're talking about. If we can this needle phobia down, if we can actually convince parents to vaccinate more children, we're saving lives for that matter. And pain is a very common reason for vaccine hesitancy. Up to 25% of Americans, I don't know about Canadians, but actually are needle phobic. Yeah. And when you actually look, and at what age group did you become afraid of needles? Probably when we were held down at 2.5 for needles at the pediatrician's office, or in the ED, or whatever happened. And this has huge consequences. Not only vaccination hesitancy, we also know numerous cases of kids or teenagers who are so afraid of telling their disease because they've said a needle would happen. I know of one kid who died of a testicular cancer because he never told anyone about his tumor because he was afraid of the needles. So we need to do better. So what did we do in children's? In Children's Hospital and Clinics of Minnesota, the first thing to change this was trying to make a connection. So as medical director, I was, let's say, invited to a 1-week lean course. So that's was not very fascinating, to put it in there. It probably was the most boring thing I've ever done in my life. And I basically started fighting with them. I don't care. But then when I started, like in those minutes when I did listen, it actually turns out that the whole idea with this lean quality improvement is getting rid of waste. And then we agreed that, pain is waste. If something doesn't have a benefit for the customers, in our case the kids or the parents or the referring physician, there's no benefit for any of those 3 in it, then this is waste and we should get off the system. And suddenly I was listening. Yeah. And then I told them, everything you do is boring. Like, I don't care about syringes in the emergency room better organized. I don't care. Yes, it's like, yeah. But this I care about. And our lean office took this on, and they actually did assign a 0.5 lean person for the last 5 years to make this happen. So that was the big idea, using something which was already there, which was mind-boggling boring, and make it really sexy by defining what is waste, and that was pain. So our hospital is one of the largest children's hospitals. We have about 385 staffed beds on 2 campuses. Half of them are ICU beds. We have 7 ICUs, so most of the kids are pretty sick. 2 EDs, and we have 26 primary and specialty clinics. So it's sort of it's a busy place with more than 96,000 emergency room visits per year, 14,000 inpatient admissions, and so on. You have all these numbers in your slides if you have any trouble falling asleep tonight. So the idea is when we were sitting down is, okay, is really, we agreed on with all data Neil has shown, and we did our own data as well, pain in children's hospitals, even now, 10 years after the decade of fighting pain, is very common, is under-recognized and under-treated. In our hospital alone, 200,000 children are suffering from needle pokes every year. That's just within our own institution. Yeah? And we have 2 other children's hospitals in the city. And when I talk about needle pain, we talk about all elective needle procedures, vaccinations, blood draws, injections, IV cannulation, lumbar punctures, and so on. And it happens everywhere. It happens outpatient and inpatient and on units and on clinics, and it happens inside our hospital and 30 miles away in a clinic. So we want to change this. So we looked at the evidence and thought, well, there are actually 4 things. So for the new hospitals, those of you who are not ChildKind certified yet, if you come back tomorrow and said, okay, guys, we have decided that from tomorrow on, every single child who will get a needle in our hospital will always have topical anesthesia on, with some cream on. We will give sucrose or breastfeeding for all infants 0 to 12 months. We will not hold them down anymore, ever. And we will always use distraction. What are the top 5 reasons you're going to hear from your colleagues about why this may not happen? Would love to do it, no time. Staffing. We do not have staff for this, yeah? Ain't gonna happen. What else?
Takes too long.
Takes far too long. I mean, I'm really good at this. Like, I'm pinning them down, I put the needle in 98%, 5 seconds, right? Yeah. What else? Who's gonna pay for the cream? Yeah, the topical cream, yeah? Can't do that.
How are we gonna train people?
Pardon?
How are we gonna train?
How would we possibly going to train people? Pardon? Oh, the cream actually doesn't work. I mean, that's such a placebo. Yeah,
It makes the needle stick harder if it contracts the vein if you use.
Right, it contracts the vein. Yeah, because then you sort of can't see that. Anything else?
If you try 1, 2, and 4 and those aren't effective, you're going to have to hold them down.
Right, if that doesn't work, then clearly you have to pin them down, right? I mean, there's no other bloody way. What else?
They should suck it up.
Just suck it up. It's just a needle poke, really. I mean, we turned out well, didn't we, Carl? Yeah? So we heard, of course, the same things, right? And, I came to Children's in 2005. We have this bloody pick a question, like, how did we did? And sort of we went better, like 1% each year. The parents were telling us, like, oh, that's good. I can go to retirement, and very soon. Yeah, we were above the national average in the United States for children's hospitals. So I thought that's really sort of good. So in 2013, we had like 87% of the parents tell us that we really did everything possible to control pain. So yeah, why doing? So we just asked our staff, okay, guys, how are we doing? And they told us that we're doing great. Yeah, we did a huge survey among all the staff, and they basically said, there's really nothing to improve. We do pretty good. Children's Minnesota is an amazing hospital, amazing pain team. Thank you that you're there. Next topic. Then we actually asked the patients, and turns out that was not actually based on any facts. That's more an alternative fact. So hands down, we published this, and we just did our second one. The number one thing kids told us what they experienced in our hospital in the last 24 hours was needle pokes. Was the worst pain, the one they felt we did least well about. Hands down, 40% was the worst pain in the last 24 hours. And we just submitted our follow-up survey, so hopefully this will come out soon. So we had to change culture, right? Because the attitude was, either we heard from our staff, well, the needles don't really hurt that much, or, well, there's nothing we can do about it, right? These were the options. It's not bad, or there's nothing we can do about it. Yeah, hold them down and do it quick was the main thing we heard over and over again. Or, yeah, but just get it the first time. That's really important. The reality is, yeah, it hurts a lot. And it causes an amazing amount of anxiety. And we have solid evidence that those 4 simple steps we just talked about really, really work to prevent or at least decrease the needle pain. So we had to change culture, and that's the tricky part. So how did we do this? How did we come from 0% adherence of having all these things happening to now 200,000 children a year? And so changing color is difficult, yeah, because we had to convince people that what if getting shots does not hurt? Like, what if we were to do that? So we actually developed the TT changing behavior tool. It works 100% of the time. It increased actually the work productivity by 46%. So we just submitted this to Payne, so it's with Eccleston at the moment.
When we asked Reebok to send us Terry Tate, some people thought we were crazy. But I'm a firm believer in paradigm breaking, outside the box thinking. Hey, mate.
It was over 15 minutes ago, Mitch!
And since Terry's been with us, our productivity has gone up 46%. We're getting more from our employees than ever before.
You know you need a cover sheet on your TPS reports, Richard! That ain't new, baby! Hey, Janice!
What's really impressed me is how Terry's become part of the Felcher family. He fits right in here.
That's a long distance call, Doug!
To be honest, I wish Reebok sent us 10 Terry Tates.
Woman, it's game time! It's pay time, baby!
All right, okay, I admit I lied, it didn't work that way. So how do we eliminate or reduce pain caused by needles? And to quote one of the most famous American philosophers, Joe Tribbiani, it's not rocket surgery. Yeah? So let me introduce you to two spectacular experts with first-hand experience with needle pokes here at our own institution, who will show you how to help your patients to have much less pain caused by needles. Thank you.
No one likes needles, especially kids. Am I right?
You are, and I can back that up with the facts. In a recent poll of patients and parents at Children's, we found out that needle procedures are rated as one of the most painful parts of their experience. Most kids rate needle pain as a 6 out of 10.
Speaking from experience, that sounds about right.
And get this, about 1 in every 4 adults has a fear of needles, probably because of the experiences they had as kids.
But it doesn't have to be that way, and that's why we're here. There are 4 simple steps we can take with needle procedures, like lab draws, vaccinations, and IV starts that make it a way better experience for patients and families. And isn't that what Children's is all about? Making it better for kids?
So here they are. Step 1, numb. Always numb the skin first. There are lots of ways to get it done. Just make sure it happens.
Step 2, sucrose. For babies 12 months or less, giving them sucrose works like a pain blocker.
Step 3, positioning. Always use comfort positioning. Ideally, children are sitting up with the parent close by.
Here's my favorite trick. Step 4, distraction. Games, videos, bubbles, books, music, bring it on. Anything fun to get your mind away from the needle.
Afterward, make sure you tell us what went well and encourage parents to provide comfort. They'll know what to do.
And that's it. 4 simple steps to help make needles less painful and the new standard of care at Children for all needle procedures.
That's awesome. Let's take a closer look at each of these steps.
So starting this quality improvement project was, we call this this lean project, a value stream. We basically defined what were the non-negotiables. We didn't call this that because people didn't like the term. And we also said, okay, what if that doesn't work? Because there is a certain amount of kids who already were scared in the past or would be needle poked. So we needed a plan B or a deferral process. So we're gonna talk about this. So step 1 is topical anesthesia.
There are numbing agents available that can really help with needle pain. Why wouldn't we use them? Critical care areas, they have J-tips that are easy to use, work immediately, and last around 20 minutes.
4% lidocaine cream is available everywhere, even without a prescription. It needs about 30 minutes to work, so you have to plan ahead. It lasts for about 1 hour. You can cover it up with Tegaderm or cling wrap so kids don't get it in their eyes or mouth. But it's worth the time and effort, believe me.
Yes, that's for sure. Emla is a mix of lidocaine and prilocaine, and it needs a prescription. It takes longer to work, around 60 minutes, but it lasts longer too. So even if parents put it on at home, it will still be effective. Both creams need to be wiped off just before the poke. If the creams cause the veins to constrict, don't worry. A warm cloth or warm pack will reverse that in 5 to 10 minutes.
So in our hospital, since in the United States lidocaine cream is available over the counter and it's not very expensive, and for Emla cream you do need a prescription, we basically got rid of Emla cream with very few exceptions and use lidocaine throughout the system, 4%. And Anna Taddy actually just published of all the things we can do to reduce or minimize vaccination pain. Lidocaine cream, hands down, is the pillar of that. So that's the one thing we can not get rid of by any matter. We heard this left and right, and everywhere it goes, it constricts the veins. So we have now, we do it for 200,000 children a year. We had not one single case reported of a child with constricted veins. We always tell them we would put a warm pack on, it's going to happen. It hasn't happened yet. And there's data to that support that, that in fact with J-tips or with Emla creams, in fact, it's clearly not less likely to cannulate the vein for that matter. We have a very busy emergency room, 96,000 kids a year, so, and many of my colleagues are not prone to wait 30 minutes for cream to work, so we needed a plan B.
But a needle poke without the pain is now possible. 11-year-old Sam Sauer agreed to show us in the emergency department. Were you scared to come in?
Yeah.
When Sam was 4, he had to have an IV.
And it was horrible. He had to be restrained at the time.
Now the older, braver Sam is trying what's called the J-tip. It's a syringe with a small canister of pressurized carbon dioxide. It pushes lidocaine, a numbing medication, into the skin. And how quickly does this work?
30 to 60 seconds.
Then when the IV needle is put in,
Good job, buddy.
Is it done?
Yep, the needle part's all done.
Sam seemed shocked when he compared the stick to a bee sting.
This was much more better.
Kathy Walsh, CBS 4 Morning News.
So the J-tip is not any better, it's only faster. In fact, the cream is much better because it covers a bigger area, and for that matter, but that's something we would use. Step 2 is breastfeeding, or if we can't do breastfeeding, then sucrose for infants younger than 12 months.
For babies 12 months or younger, you should also use sucrose. Breastfeeding is another option. Evidence shows that they both work like a pain medicine and actually block pain messages from moving to the baby's brain. Pretty cool, huh?
Yeah. Sucrose or breastfeeding need to be started 1 to 2 minutes before the needle procedure. Staff or parents can put sucrose on a pacifier or on a parent's finger and let them suck, or just squirt a little bit into the side of the baby's cheek. The baby doesn't swallow it, it's just absorbed in their mouth.
It's fast and easy and doesn't have any side effects. It won't affect NPO status or alter test results. It just soothes the baby and makes it easier for everyone. Talk about a win-win.
That's for sure. There are a few exceptions with premature babies, so check with the providers on your unit if you're unsure.
So I will not go through this. We have significant amount of data supporting the use of sucrose and especially breastfeeding. It's not the breast milk, it's the fact the skin-to-skin contact. So if you have the choice of just giving a few drops, then you would rather prefer the sucrose rather than the breast milk. And of course, when we rolled this out, I will talk about this in a second, there were gazillions of reasons why this could not happen, right? And at the end of the day, the new way has to be easier than the old way. So for instance, if the sucrose is not in every single room, it will not reach the baby. Yeah? So if it's in the pyxis, it's not going to happen. So we basically need to make sure that's in the room. If you're supposed to breastfeed on the NICU and you allow this, and then the phlebotomist is supposed to do this, they may, that hurts their back. So we need to actually invest in $3,000 for stools so that they could be in the room, so that people could do that. So we have to change the environment at the same time. And really, at the end of the day, I said, okay, I need in your unit cream on the child. You're the person who has to put this on. How can this happen? So, yeah, and then you decide how to do this. I don't care, as long as the cream ends up on the child. So the frontline staff, the person who was in that particular unit, had to decide they decided how to get on. It was not negotiable whether or not. Yeah, it was basically how do you get it on. That's your task. How do you get the sucrose inside the baby? Yeah, so and that was the frontline staff doing that for this matter. So again, this is not step 3 positioning. This is not optimal for an IV blood draw.
Parents are baby's best source of comfort, so we need them to be involved, ideally by holding them. For babies under 6 months, it also helps to swaddle them. It makes them feel safe and comfortable and decreases the pain they feel with the needle. Skin-to-skin contact is another option, which has been shown to increase babies' comfort. Be sure parents know how to do this before the procedure. Aw, I love babies.
As children older than 6 months feel safer and more in control if you have them sit up. It's best if parents or caregivers hold them. It depends on the age and what procedure you're doing. For vaccination, chest-to-chest is usually a good option. Or you can have the parent hold the child sideways on their lap with the child's legs between the parents. For lab draws or IV starts, having the child back to chest works best.
School-age kids may or may not want to sit on their parents' lap. Let them choose. Make sure you take the time to hear what they want. But remember, upright is always best.
For teens, and I can speak with good authority on this, make sure they are upright and comfortable. If they want a parent or caregiver close by or holding them, that's their choice.
So I just Googled this after Neil is actually showing this. You can still buy this in 2017. Yeah, those bloody poo-poo spots have to go. Yeah, this is not sedation. This is not analgesia. Use of a strain is never ever supportive. If we ask children about their experience, they tell us that it makes them feel ashamed, humiliated, powerless. Yeah, they report that they're having lost the right to control their own body. So I don't know about the culture in yours, but in the Midwest, in my hospital, it's very, very consensus-driven. It's very Midwestern, so which basically means if I do not explicitly say yes to this, then I don't have to do it. Yeah, so if I just do not say anything, then I don't have to do that. So meaning people sort of, this is a great idea, but I personally don't have to because I didn't say yes to that. And in order to change this, we really had to make this a top-down, bottom-up strategy. So we actually sent out a letter signed by the whole C-suite, the chief medical officer, chief operating officer, chief executive officer, and said, okay guys, we're going to do this. We expect for every single elective needle poke that the numbing cream is going to be on, and we will not hold children down. And then that's what was like going into a wasp nest. And then suddenly people who we would not expect 2 years later into that project showed up, then they showed up. And at the end of the day, they had like gazillions of bizarre reasons why this could not happen, including that the infants would like eat the numbing cream and then die. And like, I mean, there was like zillions of things. And at the end of it, we hear you, but we're still going to do that. And that was a culture change for our hospital. Yeah, this because it was, to this point it was, well, yeah, we hear you, then you sort of, no, we hear you, but we're still going to do it. So do not hold children down for elective procedures ever. Yeah, you need a plan B. For some kids, this is not going to work. So for each unit, we have like their own posters of pictures, how we can do comfort positioning for, and parents are not partners in crime. Their job is not to hold down their children. I mean, that takes 5 years of psychoanalysis later on to undo this. We want them to comfort their children. This is like something we've made for the emergency room. Each unit has a different sheet for that matter. And kids younger than 6 months, we would do swaddling or facilitated tucking or skin-to-skin, ideally, if we can. And lastly, it's basically distraction.
I know this is supposed to help the kids, but this is really helping the staff do a good job then.
Distraction makes all pain better, including needle pain. Of course, you have to think about the age of the child. For babies, singing or making rhythmic sounds like shh works well. They also like musical toys or things that spin or light up.
Toddlers and preschoolers need something more active. Bubbles, pinwheels, interactive stories, games, or videos. All keep them busy.
School-age kids need more options, and some even like to watch. Make sure their choice is theirs. Interactive music, books, stories, phone apps, videos, and yes, even bubbles and pinwheels all work well to distract this age group.
We teens often bring our own distractions along. If we have our phones, we're automatically distracted. I like to put my headphones in and listen to music or play a game.
Sorry, I was distracted. After the needle procedure, let us know what went well. Keep it simple and encourage parents to provide comfort. They'll know what to do. It really helps to remember what worked and, hey, have parents jot it down so that they have some tricks for next time.
And that's it. 4 simple techniques that can significantly reduce pain and fear with needles.
Part of the Children's Comfort Promise. Together, we can all make a big difference.
Because is there anything better than a smiling kid?
I don't think so. I really don't.
Me neither.
So when we started rolling this out, we thought, okay, what is the low-hanging fruit? And we decided to start in the outpatient lab because there were only 14 or 15 phlebotomists, and they poke 30,000 children. So I thought that's a low-hanging fruit. The employee you just saw there, she is the head phlebotomist. We sat down. We had like a several-day environment. Her body language was, over my dead body. And it was basically, and it was like, whenever I said something, I showed this move, this line. So we asked her, like, what are your concerns? I said, I get this, I've worked here children for 23 years. I get, on first try, 98%. Nothing you're telling is going to work. Yeah? So it's not going to work. I mean, that is how we start. I said, oh, great, this is going to go well. We put this in, and what we always do is, like, we said, okay, these are the 4 non-negotiable things you have to do this. What are you worried about? And then it was like time, waiting time, the vein would be constricted, and this wasn't going to happen. So we measured this stuff as well, the stuff as well. Turns out waiting time actually went down. So now, before that, it took them 20 minutes from check-in to until the kids were leaving. Now it's 16 minutes because you don't have to hold them down anymore. It's actually much faster. Also, what happened is, like, she got up in the morning and then saw kids screaming from the car going into her lab. They would scream while she was doing it. They were screaming on the way out, and the siblings would be screaming. Now they're stopped. Yeah, hardly ever do kids scream anymore in this thing. And now, the staff turnover turned down. Like, we, at the time, 52% of our phlebotomists quit within 3 years. Apparently, poking screaming children all day does not have high job satisfaction. So now our staff turnover in the last 3 years, now it's down to 12%. Yeah, so again, which saves significant money for our hospital, for that matter as well. And whenever I see Eve now, she's like beaming, Dr. Friedrichsdorf, how are you? Yeah, and she's an absolute convert of using those modalities. And having somebody who's so critical then as a spokesperson really, really helps for that. We are not making this up. Most of this research is coming from Canada, and really is already implemented as a recommendation. As usual, they're like 10,000 years ahead of us in not only research, but putting this in. So you can download this. I'm here from the Canadian Pediatrics Society, from Sick Kids, immunization, those 4 things. So it's all out there. So we decided to do this in a quality improvement step by step. We started in 1, which took the longest, and then we used this and went to the 2nd unit, which took still long, and then each time we did it was faster. Initially we started with like a 4-day project with a group, and then it took, like, at the end we did like a half-day one. So things sort of improve over time to do that. And to really make sure that what we learned in 1 unit then can go to the next one. The goal was that all 4 modalities are offered 95% of the time. We would do audits until they've reached 95% 3 months in a row. Because we found once they reach 90%, then they don't go back. So there were lots of attitudes, right? And knowledge and skills we had to do that. People have time, we told this. The stuff wasn't there. We have to make sure who pays for this. So we had to go to the Department of Health Service in Minnesota to make sure that the numbing cream would be reimbursed by Medicaid, Medicare, like acetaminophen, Tylenol, or such as ibuprofen. And actually in first try, which is very surprising, they did do that. So meaning now if a pediatrician prescribes the numbing cream, it will be reimbursed by health insurances. Space, like there wasn't often enough room and it's all there. And then, of course, there are many, many roadblocks. Yeah? And we just submitted it to Pediatrics. We're in 2nd review. We have like a long list of 64 roadblocks as the list in there. Some examples are accidental needle sticks. By not pinning, they learned you have to pin them down, right? Because otherwise it's going to be too dangerous for needles. So we had one single needle stick, and by looking through this was a severe autistic violent child, which never, like no bubble blowing on earth is going to help doing this. So the whole system was wrong at this clinic. Other than that, we didn't have any. There weren't any order sets, right? So in the past, in order to get the numbing cream or the sucrose on the child, a physician had to actively, or a nurse practitioner had to order that. Of course, it never happened. So we just changed our computer system that every time somebody orders a blood draw on IV access or vaccination, that automatically the numbing cream and the lidocaine and the sucrose pops up. So then people have to unclick it if they don't want it. And of course, then order sets went from 0% to over 99% overnight. I told you vasoconstriction, we did not have a single case. And if it were to happen, right, we could put some warm packs on there, but it didn't. We talked about insurance coverage. Quite a few kids don't like the tegaderm sort of being pulled off. So we use either cling wrap from Costco, or we actually found some foam tape, which is actually quite nice. It's fairly cheap. You just sort of cut it off and you can put it on, and that does not hurt when you're taking this off. Takes too much time to wait, so you have to change the process. And a clinic for vaccination, they can choose to send parents home with the cream and they put it on there, or they can choose to sort of do it in the waiting room. So that, again, that's the choice of the individual clinic. For that matter, internally, waiting time has significantly decreased. So as I told you, went from 20 to 16 minutes for our labs. On the NICUs, we measured the time, because in the past, the nurses had to calm down the sick babies, increase the oxygen for 10, 20 minutes after they were poked. And now the babies actually sleep through it, so that the nurses have actually more time to attend to other things. So sucrose had to be in every room. And they basically felt that that offering all 4 things was time consuming. And initially people thought they can choose one of those 4 things and then it's going to be fine. But it's all 4 things. And we really had to do time studies to show that this is shorter. So this is like an amazing example. This is our NICU in Minneapolis with, they have about 60 beds and plus 40 step-down beds, so it's 100 beds in total. And they went from 0% offering any of those modalities, of those 4, to more than 95% within a few months. And of course, it worked everywhere like this, not. Yeah, so this is like what we're struggling with right now. We have 26 clinics in the suburbs. Yeah, this is one of them. Again, it's not bad. We went from like 0, yeah, in June to now like 81% April, but we're not at 95% yet. Yeah, so the vaccination thing out there is much more difficult out there, because it's 3 minutes in and 1 minute out. Still, it's not bad, but we're working then. We will continue to audit until we reach 95% in all clinics. All the time. Satisfaction scores, not surprisingly, went up. So I think the question, amazing stupid with this picker scores, right? Has the staff done everything, control the pain or help with the pain? But we had an increase of over 10 to 12% within 2 years. And there wasn't nothing else was going on at this time. It really sort of has changed. So that means that, and usually in the quality improvement world, if we get better with 1% per year, that's sort of an appropriate goal. So 10, 12% is actually not bad. Hand washing in our institution, it took us 4 years to get from 50% to 90%. And that's a task most physicians really learn at the age of about 2.5. Yeah. Yet it took 4 years to sort of get there. Only now in year 6 are we above 95% in hand washing and compliance among our staff. Yeah, that's just one task. So considering that as a bundle, this is actually not bad. So as I told you, wait time is decreased, satisfaction is increased. We had no venous constriction. We have system learning reports. So whenever something goes wrong, you put this in the computer system. And the ones about pain went down by over 50%, and specifically those about poking poor babies into the heels. We do it less often, that's one thing, but also we're using those modalities. Because now most infants are really sleeping through their lap draw. And staff turnover has decreased, and that actually was a really good argument for, especially now in financial tough times. I heard UCFS just had magnet visit yesterday. Yeah, right, Lisa? So yeah, we're getting our in October. So before we did this, only 8 out of 21 units outperformed the mean for pain scores. After we started, 19 of 21 were outperforming mean for pain scores for the magnet results. So that actually made our magnet team very happy. So you remember Marius? I told you that at the beginning. What is the plan B? Yeah. So this is my best friend's son who was playing with my 3 children in Minneapolis at the museum, at the Mill Museum, and he was chased by my 3 kids and ran frontally into a metal pole and had a long sort of gushing wound on his forehead. So you could see the periost. He was bleeding bloody murder. So I put the screaming kid and his dad and my 3 kids into our minivan. I drove to our emergency room. And like most reasonable emergency rooms, the policy is if the triage nurse thinks stitches might be in order, they already put the cream on. So we had lead cream as the open wound. So we waited for 30 minutes, had lead cream on. And then he got actually a large number of stitches. I think it was 18. He needed like 3 layers, periost, medium, and then top, like 6, 6, 6. And what I saw during those 18 stitches was the following. So he's sitting upright. We've numbed the skin. And let's agree he's distracted. So why on earth would we hold down children like Marius if we can have this more than 95% of the time? We do need to plan B if this is not working, right? There are kids who come in on wheelchairs with cerebral palsy, who are bad stick, who have been held on the path, already screaming. No amount of distraction, bubble blowing is going to work for them. So then we need child life clearly. If they haven't been involved by now, you really need them then now. If kids really truly have needle phobia, I have 3 pain psychologists on my team, they would see kids for needle phobia. It's often 2, 3, 4 sessions of desensitization of CBT where you can actually overcome this. If you know those kids will need intramuscular or subcutaneous growth hormone or whatever sort of for the next years to come, you can actually go through this. Or we do sedation. So we are, I believe we're one of the, if not the largest program in the country using nitrous gas for procedures for kids, which is nurse-led in our hospital. And if that doesn't work, we would ask our anesthesiologist from the sedation team to think about moderate to deep sedation. And we only do safe kids for nitrous gas. So there's a very comprehensive checklist so they have to be fairly healthy, no older than 1 year, no issues with airway, so all of that. And with that, we have extremely good experiences with that. So that's is an example of a typical 22-year-old little tiger has been poked a lot in the past. No amount of distraction was really going to work. So this time she was then, if I need a kit, I just call my short stay unit and say, okay, I need in 3 days from now, I need that IV access or the blood draw. Then they sort of just book this in. So this is the nurse doing the nitrous gas. Dad is holding her daughter. Of course, we still put the numbing cream, the lidocaine cream, on the skin. And veins seem to pop up with the nitrous gas, so it's easier to cannulate them. Kids are fully awake. They do not have to be NPO. They can eat and drink right up to this intervention. And they can walk out. They do not need any time afterwards for observation. And if there's any risk on this checklist, then they would be assessed by a pediatric anesthesiologist who then decides whether or not nitrous gas would be safe for them. So what have we learned? The new way has to be easier than the old way. If you want to change something, clearly, yeah, if it's more difficult than the old way, it's not going to happen because so many people have workarounds for that matter. The frontline staff who has the work needs to make the decision how this is actually going to happen. Yeah? Me writing a protocol is not going to change anything. You need bottom-up, top-down. So you need your leadership to actually say, okay, at the end of the day, we're going to do this. Even if you choose, you don't want to be part of this, you don't have a choice. But you also need enthusiasm from the troops on the ground to do that. So, and it's a lot of the number one thing, I think, why we were able to put this through is that we put actually one nurse full-time, my chronic pain clinic nurse, went for the last 3 years now full-time into this project. Her main job is to make the system-wide. She attends all the meetings and she's there Monday, Tuesday, Wednesday, Thursday, Friday to sort of do this. Doing it as a hobby on the side is fairly difficult. And make sure it's a win-win, so that when people are doing this, they actually it's better for them, it makes their life easier at the end. Perfection is the enemy of progress, right? And perfection is the enemy of good. There were many roadblocks, and we could just say, okay, then we can do it. So we decided to start with good, and then make it better, and then sort of go with perfect. For instance, initially we found out, we started with a lab, and then the phlebotomists in the state of Minnesota are not allowed to apply the cream. So we could have stopped. Well, we wanted to do this. So we decided just with the other 3 things. So we had to find workarounds how to get the cream on the child, but not being by the phlebotomist. The parents are now doing this, or the clinics who refer them have to put this on, yeah. And so the parents can put on the cream, but the phlebotomists are not. So some of those things are insane, but then we started with good rather than perfection at the beginning. No, we hear that a lot, and then it's why. Yeah, it's the 4 whys, or sometimes 5 whys, yeah, before you sort of really get there. And it needs to be sort of part of a protocol of your computer system of all of this all day. And there are gazillions of groups I've never heard about. We suddenly had a new vaccination committee on this, right? And so we had to be part of this. Or we have a phlebotomy access nurse committee and a sedation pain committee and all those things. So having Donna, like my amazing nurse for this, who walks on water, in there is absolutely fabulous because she could put that. So we now do it for in pretty much all units, with the exception of a few outpatient clinics. We have reached 95% for these kids in the emergency room, in the PICUs, in the NICUs, and all the inpatient units. It's QI strategies, pretty boring stuff, but it's very sexy if you decide that pain is the waste. We use knowledge transfer strategies as a key component. And people seem to be interested in that. Like when I talk about this, oh, we can actually do this as well. And thank you, Christina. The Mayday Foundation actually gave us a grant so that we can move this to 4 other children's hospitals, so to Montreal Children's, SickKids Toronto, Atlanta Healthcare, and Mercy in Kansas City. And we sort of just said, okay, this is what we've done to encourage them to use this in 1 unit, and then people can move this on. And it all will be rolled out in all 4 hospitals within the next 3 months, and 1 already has started. So these are pictures out of the newspaper, New York Times, yeah? So how many mistakes can you spot? Where are my ChildKind to be hospitals? Where's room for improvement here? They're holding them down, right? That's not comfort positioning. Okay, we can do that better. What else?
In the picture on the right, it looks like the baby might be all alone. There isn't even a parent there.
There isn't, yeah, baby's all alone. Doesn't look like sucrose, does it? No. Or breastfeeding. Let's guess there's no numbing cream, yeah. Pardon? They're not very distracted, are they? Those of you who are trained like in hypnosis, yeah, the kids they're already in hypnosis here, right? I mean, they're so focused. You can easily get them to different places. So let's not do this anymore. Our executive sponsors, which is something we use for value stream, are people who can move problems out of sight. In my case, was the chief medical officer and the chief nursing officer. And these are the amazing team, core team, Donna Yule, our nurse, and our coach, Christian Widener, who is our engineer, the lean consultant, who did that. And with that, special thanks to that, if you have there are more conferences coming up, including Basel in 2 years from now, Pain Masterclass and Palliative Care. Grab me in a break if you have more interest in that. Any questions, comments before we go to a break?
How did you make sure that all of your nurses were actually doing this? Did you have them a checklist, or I feel like some nurses would and then others would just say it and then.
So the question was, how do we make them do this? So what happened is we decided to move it out on the inpatient floors, right? So basically you would go, okay, on the hem-onc unit, right, which is our 7th floor in Minneapolis, you basically sit down with the front staff, the charge nurses, the manager, and said, who needs to be around the table to make this happen? And then we said, okay, guys, this is what we're doing. In the rooms, for instance, we had a little thing. So at intake, the intaking nurse has to ask those 4 things, like for distraction, what would you want? For the numbing cream, how do you want to do this? And then we had people who were basically, there's in certain shifts, 100% of the kids declined all those 4 things. Yeah. So we looked at the data, said, how did this happen? Turns out the nurse actually didn't ask, right? She declined. Yeah. So by auditing it, you just get the number and you present this once a week or once a month and look into this. And we have it now on the computer system. So it's basically, so it has to be charted. If you put a needle into this kit, are those things done, yes or no? So it's sort of, people are not convinced. You make this happen, and then the stories come. People who didn't believe in this, now then they come us, we videotape them, okay, tell me that story again. I said, I thought this was full of crap, but I've done it, this was amazing, it really was well. Yeah? And using those people as influencers at the morning huddle to get this in. So this is how inpatient was actually easier than we'd have thought. The outpatient is was the much more difficult one because it's MAs and a very sort of quick turnover. But there's people, yeah, especially at night shifts, I ain't gonna do that, yeah? And you have to audit and then put this down. Does that answer your question?
Yeah, I'm in the ER and I feel like everything's rush, and I can just see a lot of, in theory it sounds good, but they're gonna be like, well, this takes too long. Now that I see, I'm like, well, it saves time, but convincing them, I'm not.
Again, it's if the new way is harder than the old way, it's not going to happen. If your ED nurse has to go to the Pyxis, to the other way of the unit to get the sucrose, it's not going to happen if she's busy. If the numbing cream is in the Pyxis, it's not going to happen, right? So you need to make the system easier. If you expect people to breastfeed and to draw blood, they have to sit on something. You need to have the space, right? And this only comes out if you actually sit down with your emergency staff. Okay, this one to what problems do you foresee? And then it's the vasometric, and then say, okay, let's measure this, yeah. And then you can prove, well, waiting time actually does go down. Yeah? And then people sort of change if you can actually address those concerns.
Did you have to hire people to do the auditing, to do the reports for the auditing, and what was that cost, and how did you sell that part?
Did we hire? No, so the only staff we had, so we are a 385-bed children's hospital, is a full-time nurse, and we had for 3 years a 0.5 lean consultant, but both of them were already sort of in the system, but that was the main job. Initially, the first audits we did ourselves, and then we actually put this on the manager of the unit. The enthusiasm to do that was not very high. Then the bonus, the manager bonus, was actually tied to the that we got the audits.
So did you have to work for professional development or nursing education?
Well, the chief nursing officer was our main sponsor, so she did some magic behind the scenes, and yes, we did that. But it was the whole training was that movie I just showed you, right? Because because they're all unionized, and if they're in union, you basically have to if you get them, you have to pay them for 4 hours, even if the training is just 5 minutes. So yeah, and we have about 3,900 nurses, so yeah, that was cost prohibitive. We couldn't do that. Yeah, so we had to do something very quick on those things. And all managers and all directors in last year, they had to choose 2 topics for the bonus, and one of them had to do with the comfort promise.
So and the other thing is your comfort promise is trademarked, I see.
What we trademarked is the children's comfort promise. So those 3 words, that's sort of trademarked. Yeah, if you do something else, the word comfort promise on its own is not.
We have one which we call the commitment to comfort. So everybody's playing on those themes, the same sort of thing.
Okay, that was what if we vary it, that would be a possibility.
Right.
I just wanted to point out a subtlety of culture. You had this nice reporter from your local Channel 4 News come out and do a story.
It's actually from Colorado.
Okay.
Yeah.
So I don't know if you caught her language, but when she showed the after, she goes, and now a braver young so-and-so comes in, and it's like, why does bravery need to be part of it?
Yeah, somebody who's like trained in hypnosis, you pick up on this, like, okay, this was not helpful. And I actually, this is from Denver, Colorado. So I don't, who's the Colorado people? Do you know her? Yeah.
Yes, I do.
Yeah. So, but I thought it was like that was the best example we had. We did, because I don't have anyone in our own hospital. Like the one I had, I didn't like as much, but I agree, the wording is not great.
Yeah. Do you use what EMR do you use? Do you use Epic? EMR?
We use Cerner.
Cerner.
Yeah.
And so and did you just say to them with needle sticks? Did you have to ask them to build in something? I mean, it's getting data that's usable easily, and if you make it across the board. So I'm just thinking of our institution, we're about to implement Epic on October 1st, and so the trying to connect a visible data that can say, hey, needle went in. Did we meet these criteria or not? How did you do that with the EMR?
So you have to drink the ranitidine straight out the bottle when you start working to get this done. So we have it takes forever, and it's like super clunky, and then it's not a priority. So the way we're doing it in Cerner is that we have a pain flow sheet, right? So I go in, I see my patient, and everything I care about, I have to tell them, okay, this is what I want. I want the vital signs, I want the pain scores, the sedation scores, the withdrawal scores, I want all medications who could vaguely any have to do with pain medication, and we added the comfort promise to those 4 things. So if you order, okay, I want potassium on this child tomorrow, we also had to change, and it was bizarre, like if you ordered something, then it went to the phlebotomist who then would come up and poke the child. So some kids were poked 3, 4, 5, 6, 7 times a day because some consultant thought it was a great idea to draw some other blood. So we also had to change the timing to like this. There's now morning time, and afternoon time, and evening time, so that unless you cause stat, then it sort of pools into the next one, so that kids would not be woken up at night and be, yeah. This idea of then the residents need to have the blood results at 6 o'clock in the morning, so we have to poke the kids at 4 to get that. We had to stop that as well. Yeah, we spoke to hospitalists, and so we're not poking anyone before 6 o'clock anymore. So, and I mean, things like this was happening. And if you order this, then automatically, if the child is older than 36 weeks of gestation, those 4 things would come up. Younger than 36, we do not have enough data for the lidocaine cream, then 3 things are coming up. If you're older than 12 months, well, you wouldn't do the breastfeeding, right? So then those things come up. But it just then pops in for the nurse. And at intake, that's part of the intake protocol. You already have to ask them and tell parents that we're doing this. The last thing which we haven't done, we're going to start probably in a month, is actually putting a huge advertising campaign about that. So until now, we have postponed this because there was always like 1 year and said, okay, we need much more time to sort of implement this. But as of next month, all parents will know that they can expect this and which number to call. And I think that will sort of help the last strugglers to get out there. We can talk more about the electronic stuff, but and I can connect it to Donna.
Thank you very much, Stefan.